Amy Weatherby and I have also interviewed many people throughout major cities on the East Coast, and we haven't published, we've just finished some of these interviews, so this is not published yet. But I wanted to tell you about 105 African-American parents that we interviewed in Southwest Florida, Atlanta, Philadelphia, and New York City and the Bronx. And we produced 1,709 excerpts from which we were able to identify 16 coherent themes. And one of the reasons that I want to show you some of these excerpts from the interviews is because sometimes when you see culture at work, it's not totally obvious. It doesn't just hit you in the face. Like if you're interviewing some woman from Colombia who says, I think that I caused my son's autism because I cut his hair too early. That's clearly, that jumps right out at you as a cultural difference. When a Korean woman says, I think my son has autism because my husband and I argued while I was pregnant, and that can cause trauma to the child's brain, it jumps out at you as something that is distinctly cultural. But sometimes, especially when you're dealing in your own language, your native language, and with things that you're familiar, you won't always be able to frame things in a way that are as fully comprehensible as they could be. So we interviewed poor African-American parents who live in poor neighborhoods and attend church in poor communities. And most of these were parents of children who had some kind of identifiable disability, not just autism, but a learning disability, behavioral issue, though some parents wanted to participate who were just parents. And there were many themes that emerged. One of the major themes that emerged was a system of power and hierarchy, or of being marginalized from decision-making. They focused on the clinical encounter itself as a barrier to intervention. Often people think that barriers to early intervention are that the parent doesn't see the doctor. But in fact, often that barrier is within the clinical encounter itself, in a tension between the control of the physician and the parent and members of the parent's social network. As Judith Leavitt has shown in the history of obstetrics, the increased authority of the clinician at the end of the 19th century in the United States was affected by the decreased authority in women's social networks and women's help groups. Only during the early 20th century did decisions about both childbirth and childcare begin to be driven by scientific authority. The long legacy of conflicts between the individual and the collective, men and women, scientific and popular beliefs in healthcare decision-making, emerges in even the most ordinary circumstances, like talking with women in the basement of a church about barriers to care for children with developmental disabilities. In their talk, mothers pitted themselves against doctors. One mother reported that her pediatrician said of an early intervention program, they're going to diagnose your child with autism. They're going to tell you he has autism, but I just don't see it. When my son was young, he screamed at night. Every night I asked the doctor, and I asked the doctor, and he said, "Oh, it's night terrors. It's nothing." I'm like, "What is it?" All they would say is, "He's fine. He'll grow out of it." My family doctor said, "Your child is fine. He'll grow out of it." I'm telling you, I spend 24. These are all different women, by the way. I'm telling you, I spend 24 hours a day with my son, and I notice these things. I went from doctor to doctor before I was able to find one pediatrician that would say it's something more. Like even with the doctors, I can't tell you how many doctors I say something is wrong, and they say, "Oh no, he's just being a boy." Now, one might look at each of these comments and say, yeah, well, pediatricians are sort of trained to say watch and wait, or wait and watch, whatever. But there might be something more to this. After all, this is a population that feels marginalized from the centers of power. They describe a sense of impotence in the medical encounter. And they understand that the struggle for some validation of the problems that they observe is also a struggle for treatment. And their comments resonate with what we know about long-standing concerns in minority communities about lack of access to care. As with discussions among African Americans about any healthcare issue, whether it's heart disease, depression, renal disease, HIV, AIDS, breast cancer, what have you, there is the subtext of structural violence. Structural violence meaning the historical, cumulative, economic and political systems that influence and constrain diagnosis and treatment. And these issues are cultural. They are cultural, but they're not just distinctive to African American communities. They are probably shared in all communities. And the words I just spoke about structural violence and the cumulative marginalization of people would no doubt strike members of First Nations groups in Canada as being about them. It could be about them. Just because something is cultural doesn't mean it's distinctive to that population. But it does mean that we need to appreciate how it enters into the barriers for early intervention. Similarly, in my comments, alluding to things like renal disease or HIV/AIDS or breast cancer, whatever, we also need to, when we're talking about autism, to look at what's happened in other areas of health. All too often, people treat autism as this island. We're just working on autism and reinventing the wheel when other people have already dealt with certain cultural barriers to care in other areas. In our research, mothers' frustration with clinical encounters consistently also took on a temporal dimension. They worried that doctors were letting the clock run out, which is to use another term from the interviews. Their comments pitted parents' sense of urgency against the doctor's wait-and-see attitude, a propensity that parents we interviewed perceived as an unfair obstacle to treatment. One mother who watched her son's symptoms get progressively worse as he aged expressed her desire for earlier diagnosis this way. She said, quote, "I think that if the pediatricians maybe take us seriously a little bit sooner, then we could probably get more help." For parents who know in their hearts that something is wrong with their child, the clinical encounter is already a site in which the stakes are high. But when coupled with parents' emerging knowledge about the positive effects of early intervention and communicated through the asymmetrical relations of power that mark doctor-patient exchanges, exhortations to wait can be seen and experienced as a particular form of violence. In light of this risk, many parents in our focus groups shared strategies for attaining recognition and getting physicians to listen. One response is simply to move from provider to provider. If you don't get what you want from that doctor, go to another one. A second response is to generate or approximate a counter-authority, which is to go to other people, like speech and language pathologists, to get ammunition. A third response to frustration and anger is to counter powerlessness with power. One African-American mother in the Bronx attributed her young son's performance on the Autism Diagnostic Observation Schedule, or ADOS, in terms of resistance. She said, "I don't think he was incapable of doing them. I think he refused. He got counted off on all those tests because he didn't want to do it." Well, there's more to these encounters than meets the eye. Not just making excuses for refusal to accept expert authority. It's not just that one is trying to rationalize her son's performance. All of these comments invoke the idiom of power that plays such a central role in the medical discourse of people disenfranchised by structural violence. Statements about the clinical encounter are therefore ideological representations. They are representations of power that are reflected in the empirical literature on medical discourse, which is replete with examples of how doctors, backed by diplomas and certificates and statistics and so on, exercise power and authority. Interestingly, in these focus groups, when we said to parents, what might make you feel more supported or what might make you feel more heard, they said, oh, this, point meaning our focus group. Our research turned out to be one of the places in which they felt listened to, where they felt that their voices were validated. Because we started out our interviews by saying, you're the experts here, because you're the experts on you, and we want to know what you're doing.